All right, let's get started. Welcome, everyone. Thank you for joining today's webinar on state actions to address substance abuse. My name is Selena Pierrota, and I'm an Associate Director with the National Association of State Boards of Education. We are supported today by our partners at the National Coalition of STD Directors and Child Trends, who we have worked with for the last 5 years to create the Leadership Exchange for Adolescent Health Promotion, otherwise known as LEAP. Thank you to our partners for supporting today's webinar, and thank you to our LEAP state teams for tuning in today. Next slide, please. This webinar is funded by a cooperative agreement with the Centers for Disease Control and Prevention, and this disclaimer language explains that all statements and opinions do not reflect the official stance of CDC. Next slide, please. Couple of logistics. This webinar is being recorded. The slides and recording will be distributed next week, as well as additional resources that we will be using throughout today's presentations. We will be using the Zoom Q&A feature found at the bottom of your screen, and we encourage you to layer in questions throughout today's conversation, and we will make sure to embed those into our moderated panel today. Also, keep an eye on the chat box as we will be posting links throughout today's presentation. Next slide, please. Our agenda is quite packed today. We will start with the welcome and logistics, followed by 2 presentations. The first presentation will be a data presentation on adolescent substance abuse, with a specific focus on the rise in fentanyl. The second presentation will focus on state health and education partnerships to address substance abuse. Presentations will lead us into the moderated discussion, which we will start by highlighting the great work in North Carolina. And finally, we will conclude with closing remarks and an evaluation poll. Next slide, please. You may be wondering what LEAP is. The Leadership Exchange for Adolescent Health Promotion is a learning collaborative of multi-sector state-level leadership teams working to break down silos between the health and education sectors and collaboratively improve adolescent health. The project is open to any state interested in participating, with the minimum expectation that a representative of the state health department and state education agency be members of the state LEAP team. 13 states have participated in LEAP, and these state teams have developed locally driven action plans focused on policy assessment, development, implementation, monitoring, and evaluation to address adolescent health. To learn more, please visit leap.org. Next slide, please. We have some phenomenal speakers today. Joey Hedger, NASBE's associate editor, will be moderating today's panel. Last November, he wrote a publication on state efforts to curb adolescent fentanyl use and has researched and written several NASBE publications on other school health topics. Joey will be joined by 3 panelists today. Marci Hertz is the Associate Director for Program Implementation in the Division of Overdose Prevention within the Centers for Disease Control and Prevention. She previously served as the lead health scientist in the National Center for Injury Prevention and Control in the Division of Adolescent and School Health. Ioana Ungureanu is the Senior Analyst of Public and Behavioral Health Integration in the Association of State and Territorial Health Officials, otherwise known as ASTHO. Ioana leads behavioral health projects, training multidisciplinary teams across states to address youth trauma, mental health, behavioral health, and substance misuse prevention. Hanaleah Hoberman is the Senior Advisor for Children and Families in the North Carolina Department of Health and Human Services. Hanaleah oversees cross-departmental efforts to improve the health and well-being of children and families across the state. She also leads research related to violence, substance abuse, and intergenerational trauma. Welcome, panelists. Thank you for being here today. I will pass the mic over to today's moderator, who will give a brief summary of the publication he wrote last fall. Joey, over to you.
Thank you, Selena. So I'm Joey Hedger, and I'm NASBE's associate editor. As part of my work on this project, I wrote a policy update that Selena mentioned last year, looking at state efforts to combat youth substance abuse. I believe Selena is going to put a link in the chat if she hasn't already. So this piece largely focused on the roles of state boards of education and state education agencies in addressing reported prevalence of youth substance misuse, as well as mortality rates, largely due to illicit fentanyl use. A number of states recently took action providing new health and prevention curriculum, educator and staff training, and resources for schools. For example, in the piece, we looked at how the Virginia and New York State Boards of Education recently adopted new curriculum and guidance for substance abuse prevention education. And Ohio and Pennsylvania both introduced the Health and Opioid Abuse Prevention Education, or HOPE, curriculum in their school systems. West Virginia also began piloting a peer leadership and school counselor training program called Game Changers. And California invested $4.7 billion in state mental health systems, which include training for behavioral health professionals and establishing universal screening and support services for young people. That's a brief summary of the publication. Again, you can check out more of those state examples and some of the other findings we found in the link in the chat. But for now, I am going to pass the mic now to Marci Hertz so she can discuss some data and trends around youth substance misuse and the effects and prevalence of fentanyl overdose among students. Take it away, Marci.
Great. Thanks so much, Joey. Thanks, Selena. Thanks to NASBE for inviting me this afternoon. And thanks to you all for the work that you do on a regular basis. As Selena mentioned, my name is Marci Hertz. I am the Associate Director for Program Implementation in our Division of Overdose Prevention, which means I take a bird's eye view to the state and local health departments and local coalitions, including our drug-free communities that you might be familiar with that we fund. Just as a personal side note, I started out my career working in the Washington, D.C. public schools in the mid to late 1990s. So schools always have a place that's near and dear to my heart. Today, Selena has asked me specifically to share with you the data related to adolescents and fentanyl. Next slide, please. So today I'm going to discuss and just give a very brief overview about what fentanyl is, why it's so dangerous, and in particular, how it's impacting adolescents. We are seeing increases in adolescent fentanyl use, so we'll talk a little bit about that and why it might be. We'll touch a little bit on what can be done to prevent it during my presentation, but hopefully more in the conversation afterwards in the interest of time. And then also in the interest of time, I'm just going to run through some resources quickly, but you'll be able to get a copy of the slides afterwards, so you're able to go back and take a look at those. Okay, next slide, please. So what is fentanyl? Next slide, please. So as you can see on the slide, fentanyl is a synthetic opioid that's 50 times stronger than heroin and 100 times stronger than morphine. There are two types of fentanyl. I think it's really important to note this. One is the pharmaceutical fentanyl, which when given under clinical supervision and really precise dosages and overseen by trained clinicians, works really well to address pain in clinical settings. But the second type of fentanyl, which I'm going to talk more about here today, is this illicitly manufactured fentanyl, or IMF, produced in clandestine illegal laboratories and distributed through illegal drug markets. It's one of the most dangerous substances that is circulating in communities across the country. It really started first on the East Coast, but has been working its way across the country now. IMF, or the illicitly manufactured fentanyl, is easier and less costly to both make and distribute and sell than heroin, and is often mixed or co-used with other drugs because of its extreme potency. Use outside its intended parameters can result in unintended consequences, including death. Youth in particular are at increased risk because drugs containing fentanyl are more available and accessible to youth, particularly via social media platforms. And we'll learn more about this in just a moment, via counterfeit pills or press pills that are made to look like other prescription medications. Youth are also at increased risk because of their lack of awareness about fentanyl, lack of awareness about its presence in other substances, and lack of experience with fentanyl, as well as lower body weight, which we'll also touch upon again in another slide. So next slide, please. So IMF is versatile in that it can be sold as a powder, dropped on a bladder paper like small candies, in eyedroppers, in nasal sprays, or made into these pressed pills that look just like real prescription opioids. It's being mixed with other drugs like cocaine, heroin, and methamphetamine. People sometimes do intentionally take it. Some people find that it produces euphoria, pain relief, relaxation, sedation, but also confusion, drowsiness, dizziness, nausea, and the other symptoms that you see here. I've included some of the code names and street names for fentanyl. I think these are really important for people to be aware of, particularly those who work with young people, because they're unlikely to say fentanyl. They're more likely to use any of these slang terms either when speaking or in text message or Snapchat messages, etc. These slang terms for fentanyl that you see on the screen here. Next slide, please. So deaths among adolescents ages 10 to 19 involving IMF increased 182% when looking at a time period between July to December 2019, and then that same time period in 2021. And among people ages 14 to 18, overdose deaths increased 94% from 2019 to 2020, and 20% from 2020 to 2021. This is amongst a pandemic in which youth report illicit drug use declining in survey surveillance, such as through the Youth Risk Behavior Survey. This reflects the increased potency of the drug supply. So more youth are using, however, when they're using, it's more likely to be fatal than it was in the past. We also have data that show that 2/3 of adolescent deaths occurred with one or more potential bystanders present, but most were either unaware that an overdose was occurring or were able to provide no overdose response. Next slide, please. Between 2020 and 2022, the percentage of counterfeit pills, those are those pressed pills made to look like regular opioid prescriptions that contained a potentially lethal dose of fentanyl, increased from 40% to 60%. What, you may ask, is a potentially lethal death of fentanyl? Well, it really depends upon a person's body size, tolerance, and past usage, but 2 milligrams, which is the amount shown on this pencil tip and next to that penny, can be potentially fatal. So you can see here, it only takes a very small amount of fentanyl to be lethal. Our data suggests that about 90% of adolescent overdose deaths involved opioids, and 84% involved the illicitly manufactured fentanyl. However, only 35% of decedents had a documented history of prior opioid use, suggesting that for many adolescents, this was the first time they used. Counterfeit pills, those pressed pills, was present in 25% of adolescent overdose deaths, and 41% of those who died had evidence of a prior mental health condition or receipt of mental health treatment. Next slide, please. So as I mentioned, counterfeit pills are now increasingly being made to mirror the look of commonly prescribed medications. So this is a bit of animation here. So if we could just press the forward button once for the oxycodone, okay, and then one more time for the oxycodone. Okay, so looking at these 2 sets of pills, the front and back of the pill, can you tell which is the real prescription oxycodone and which is the illicitly manufactured fake oxycodone? So take a look, think to yourself which one you think it might be, and then can you press the arrow key so people can see? There you go. So the bottom is the fake and the top is the real. So the IMF is often mixed with filler materials like lactose and sugars, and then mixed with other substances to increase the volume of the product and provide the drug dealers with greater profits. Fillers combined with IMF can also be pressed into counterfeit oral opioids to mirror the likeness of all the drugs that you see here. These mixtures are extremely dangerous, as the potency of illicit fentanyl is so great that, as you saw, even that minuscule 2 milligrams of fentanyl can be fatal. Social media such as Snapchat and Instagram has emerged as a flourishing new drug place made up of thousands of small-time dealers who sell both large and small amounts of drugs to individual users in local communities. We'll see here a similar pattern with the Adderall. For those who aren't aware, Adderall is a prescription medication that's used to treat attention deficit hyperactivity disorder or just attention deficit disorder. And it's been an extreme shortage, the regular prescription pills. So many folks are turning to the illegal market to obtain drugs that they're having trouble obtaining legally. If you could press the arrow there again so you can see which is the real and which is the fake. Here, the bottom pills are the real pills and the top ones are the fake ones. And then for the last example, you'll see there Xanax, which is used to treat anxiety, which is the real Xanax and which is the fake or illegally pressed Xanax. The one on the left, or maybe on your right, is the real and the other one is the fake. But you can see how even someone who's relatively educated about what a prescription pill should look like would not necessarily know if they bought this pill through non-prescription physician means would know that it contained fentanyl and was not in fact the exact same thing that they might obtain legally through a physician or nurse practitioner. Next slide, please. So the question I get asked most often is like, this doesn't make sense even from a drug dealer perspective. Why would they want to kill off the folks who are buying their product? And the answer is they're not trying to kill off their supply. As you saw, it's cheaper for them to manufacture and mix IMF with their other materials and with the other drugs. So I use this chocolate chip analogy here for many of you who bake or go and buy your Chips Ahoy or whatever brand is your preference at the grocery store. You know that when you bite into any given cookie, even from the same batch or same box, you get a different amount of chocolate chips in each cookie. So the same thing happens with the fentanyl. The fentanyl is blended in with whatever the other drug is, and then it's produced, you see on the bottom right, produced into those tablets or pressed pills. Some might not have any fentanyl. Some might just have a drop, but then some might have a fatal amount in them. And also with social media, as I just shared with you, there's always an active, ever emerging new market of potential users. Next slide, please. So with this illicitly manufactured fentanyl, it really changes the calculus of drug use among adolescents. It used to be that we saw kind of this continuum with those who didn't use at all, and then some initial experimentation or use that may or may not have merged into occasional or social use and may have stopped there. And then along the continuum might have moved into regular use or problematic use or actual diagnosis of a substance use disorder or opioid use disorder. What this changing calculus of fentanyl mixed in with the products means is that very first use, that purple box, that initial initiation and experimental use could be fatal. So the messaging and the prevention that we need to do with young people and with adults who work with young people or have young people living in their homes or coming into their homes or workplaces on a regular basis, it's very important for them to understand this elevated, increased risk. We see increased risk upon initiation in every point along this continuum, and the increases in death among youth and young adults, as well as the increase in poly drug use, so multiple types of drugs being used at the same time involving fentanyl in all age groups, are two markers of this elevated risk. Okay, next slide, please. Yes, sorry. Oh, wait, can you go back one? Sorry. So this is trends in drug use, overdose deaths among adolescents ages 5 to 24. You can see the age group key on the bottom, on the right side here. The purple bars represent those 10 to 24. The dark blue bars, those ages 13 to 19. So those bars at the beginning showed trends in drug overdose deaths in the United States. The beginning of the overdose crisis in the 1990s, shown in the and 2000s, shown in the left-hand side, was related to deaths primarily related to prescription opioids, but it's evolved in the intervening years, with heroin-related deaths increasing in 2010 and then flattening and decreasing in 2016. And thank you, Selena. And deaths involving synthetic opioids and IMF dramatically increasing in 2013. So to orient everybody, the latest CDC report shows that overdose deaths among adolescents ages 10 to 19 have increased substantially since 2019. And unfortunately, the deaths are really just the tip of the iceberg. In 2021, we also reported that the national prevalence of non-fatal suspected overdoses of those under the age of 24 in emergency departments were occurring in persistently high rates. In particular, there was a 50% increase in stimulant-associated overdoses between 2016 and 2019. Okay, next slide. I know I'm going over and I want to make sure we have time for all of the other speakers. So here is just a graph to show the change in trends of types of substances related to deaths or fatalities. And you see the gray line are illicit fentanyls and synthetics. Next slide, please. This slide here is just to show the difference by gender, with females in pink and males in blue. Although males are more likely to die of a drug overdose death, we have seen drug overdose deaths among females increasing at a greater rate. They increased over 6-fold since 1999. Which was a greater percent increase than we saw among males, which increased 5.7%. Some of these data and tables are available on the CDC website. You'll see here that it's from the vital statistics. I tried to put the source in the bottom corner, but you will get these slides afterwards. Okay, next slide, please. And this is just to show the difference by race and ethnicity among persons ages 5 to 24. I will say the gap between American Indian, Alaska Native youth and white youth, that gap is way larger among youth and adolescents, 120% than it is among adults, which is 31%. So just wanted to draw attention to that gap. Next slide, please. Next slide, please. We don't really know why we're seeing an increase. One potential reason is mental health. You see here in the Venn diagram of circles that over 644,000 youth had both a substance use disorder and a major depressive episode in the past year. And adolescents who had a major depressive episode in the past year were more likely than those who didn't to report past year illicit drug use or past year marijuana use. They were also more likely to report past month binge alcohol use and vaping. Next slide, please. So another potential reason is, as I showed on that prior slide, the overlap between poor mental health and youth substance use, where they essentially try to self-medicate feeling depressed and anxious with substances. This is from the Youth Risk Behavior Survey data. Since 2009, all of the indicators tracked related to mental health have been deteriorating. This was before the COVID-19 pandemic. We already were seeing this deterioration in youth mental health, with 4 of the 5 indicators moving in the wrong direction and 1 just staying, not improving. Next slide, please. This is adolescent substance use during the pandemic. We often saw decreases in adolescent substance use during the pandemic. We think related to a lack of social interaction and lack of opportunity to purchase substances. But even with that decreased access, you can still see here that there was a significant minority of youth who were still engaging in substance use. Next slide, please. We have been saying for some time now that adolescents are experiencing a mental health crisis that was exacerbated by the COVID-19 pandemic. This is data collected during the COVID-19 pandemic, a national representative sample of youth in grades 9 through 12. More than 1 in 3 said they had poor mental health. Nearly 44% said they felt so persistently sad or hopeless in the past year that they stopped doing their normal activities for 2 weeks in a row or more. 2 in 10 had considered suicide, and 1 in 10 had attempted suicide in the past year. Next slide here. And then just very quickly, we know adverse childhood experiences, or ACEs, are very common. We just released a paper in pediatrics, if you want to take a look, about the occurrence of ACEs during the COVID-19 pandemic. We know that ACEs are extremely prevalent. 61% of adolescents who were asked retrospectively about these experiences with an abuse, neglect, or household challenges had experienced at least 1 ACE, and 1 in 6 adults reported experiencing 4 or more of these ACEs that you see in the infographic here before the age of 18. ACEs are disproportionately experienced by some groups, which you see here in the bottom of your screen. Next slide, please. These are adverse childhood experiences as reported in the Adolescent Behaviors and Experiences Survey, again, nationally representative of youth in grades 9 through 12. 3 out of 4 high school students experienced one of those ACEs during the COVID-19 pandemic. And these students were more likely to report poor mental health and suicidal behavior. Next slide, please. This is what I mentioned earlier. Research shows that ACEs, as the number of ACEs increase, so too does the likelihood of prescription opioid misuse, illicit use, injection use, and earlier initiation of the substances. So this is a bar chart here where the colors represent the number of adverse childhood experiences someone experienced, and then their likelihood of being a current smoker, having alcohol use disorder, ever using illicit drugs, or ever using injection drugs. So you see here, as the number of ACEs increases, so too does the likelihood of engaging in all of these substance use risk-related behaviors. Next slide. Okay, I promised Lena I would go quickly through these because I feel like it's unethical to present a problem and then not present some resources to address it. But in the interest of time, I am not going to go through them, but I will share that the slides will be shared with you all, so you'll be able to go through them. So if you can just, and Selena's putting the resources into the chat for me. Thank you so much. And now I will turn it over to Ioana.
Hi, everybody. Thank you so much for having me. I'm Ioana Ungureanu, and I'm a Senior Analyst of Public and Behavioral Health Integration at ASTHO. I'm hoping to talk to you all today about health and education partnerships, especially with state health agencies, to address substance use. Next slide. Really quickly, ASTHO is a national association for executive branch officials that lead their state or territorial public health agencies. And as an association, we provide technical assistance to them, much like NASBE does to their members. Next slide. We've hosted many different projects on this particular topic, especially with CDC Healthy Schools branch on an ASTHO school behavioral health project. So I just wanted to quickly overview this because a lot of the strategies I'll be presenting later are aligned with this project. So we had an advisory committee of state and national and federal experts to talk through youth behavioral health, including both substance use and mental health, because as Marci has discussed earlier, those things are very intertwined. And so it makes sense to look at them comprehensively when you're thinking through programs, strategies, policies, etc. And then we took their recommendations and we disseminated it through a report, as well as a webinar and an intensive school behavioral health learning community. Next slide. As you will see, we've worked with 4 states to intensively work on some of these strategies, including Alaska for telehealth, Oklahoma for trauma-informed schools, Wisconsin for school workforce, and as you'll hear from Hanaleah later, working on a comprehensive school behavioral health action plan. Next slide. So before we dive into some of those strategies, I wanted to bring your attention to one additional area of data. So the National Council for Mental Wellbeing and CDC conducted a substance use prevention messaging for youth survey, and they found that 23% of youth were concerned about the use of alcohol, tobacco, and marijuana in their lives. And this carried over into illicit drugs as well. And I don't have that data in front of me, but that number is also very high. Of quite interest, it showed that of youth who reported fear that if one of their friends or themselves were using drugs, 77% thought they would be exposed to fentanyl or had concerns about being exposed to fentanyl. However, less than half reported having knowledge about fentanyl, actually knowing what it is and how to prevent it. And then 50% of youth reported not receiving any prevention programming in the last 12 months, and even less, about a third reported knowing of any prevention programming in their communities. So this really shows that there is a gap and opportunity for public health and education to work closer together and to address some of these programs. Next slide. When asked about what's important to them in messaging for substance use, not surprisingly, 76% of youth reported that mental health is one of the most important values to them. As Marci mentioned, we know these things are intertwined in research, but it's really important to know that for the end user, the students, the families, these are also very connected topic areas and should be addressed comprehensively. And some of the reasons they may choose to not use substances included that it may be bad for their health, they wanted to make healthy choices, they were simply not interested, or that it might mess up their future plans. Another interesting data point is that it showed that 60% of youth said that family mattered most to them. So their family's opinions and not their peers' opinions matter most to them. As we know, public health works within communities and families. So what can we do to work with families and make sure that there is connection between schools and families when discussing these topic areas? Next slide. So the advisory committee that I mentioned earlier recommended some key partners for cross-sector planning, which includes as a core education, public health, and treatment and recovery sectors. But we cannot forget the communities because no work can be done with or without the communities. And in addition, we must work with academic and nonprofit sectors. So that includes, for example, healthcare associations or faith-based organizations, peer recovery programs. And so these are just some ideas for you to think about stakeholders when you're engaging with health, between health and education on these topic areas. Next slide. For school health planning, I have two frameworks for you to keep in mind, but these are not exclusionary. There's not one single framework that will help you address substance use and mental health in your states. What I urge you to do, though, is to use a comprehensive approach to student well-being and connection. By being too singular and focused, you might miss some of the underlying reasons why youth are using substances such as fentanyl or opioids or marijuana or any other substances. And some key things to think about when picking a framework or thinking of a comprehensive approach is to make sure that there is involvement with the community and families, as mentioned, that there is a connection with data and data-driven action, and that there are healthcare services in school settings to help students address these issues. Next slide. As I mentioned, data-driven action, and as Marci had said, it's important for states to look at multiple data, even within their own states and localities or schools, across different sectors. So for example, chronic absenteeism data can be a great indicator of substance use or behavioral health issues, mental health concerns. So those can be data that can be combined to show a complete picture of what student health and well-being looks like. And I also added in here an infographic from Maine, because I want to urge you all to think about using a strength-based lens to understand youth behavioral health. I know a lot of times we go straight to the overdose data and straight to the suicide attempts data, but there's also an opportunity to look at prevention. So for example, Maine looked at whether youth felt like they mattered in their communities and whether they felt like they mattered in their school systems. And what they found is that youth that felt like they mattered were much less likely to report suicide attempts and any type of substance use disorder or substance use, showing again that you can play around with data in different ways. Next slide. Expanding the capacity of school workforce to address behavioral health can also address both youth mental health and substance use disorder comprehensively. Of course, it's important to keep working on developing school psychologists, social workers, nurses, and training them. But I would also urge you all to think about training and improving staff health literacy across teachers and other staff within the school settings. And lastly, we need to help the helpers. If the parents and if the teachers are not prepared to see potentials for substance use disorder within the youth, they're much less likely to be able to address them. So they need to be helped themselves. So we gotta help the helpers so that they can help the youth as well. Next slide. For trauma-informed care, much like Marci had mentioned earlier, we know adverse childhood experiences, or ACEs, is very, very tied to substance use. And so one strategy you all can think about is enhancing trauma-informed care, such as a prevention campaign or skill building exercises within school settings, improving relationship skills, working with your health department on home visiting programs. Those are all opportunities to think about ways to reduce trauma and the impact of trauma on students, which can later lead to substance use disorders. Next slide. And then as you're noticing, this is kind of going along that continuum of prevention. And so we're getting closer and closer to what do you do when students actually need that treatment, when they need the services and not just prevention. One opportunity is to think about working with the Medicaid program to expand access to school behavioral health services in school settings. And this is, for example, of MAP from Healthy Schools campaign that shows states that have expanded Medicaid programs to allow different types of services in school settings. If you're interested, please go to that link. They have incredible resources, and I'm happy to create some connections as well. And of course, school telehealth services is another opportunity to increase access to services for both mental health and substance use. Next slide. And then, of course, we need to address the crisis as well. So I wanted to share this one slide around naloxone access in schools. As Marci had mentioned, naloxone is an opioid antagonist reversal that is FDA approved. And many schools, 30 different states, have expanded access to naloxone in schools, with 10 requiring a policy related to naloxone. And so it shows that there is movement in this area, an opportunity to make sure that there is access to crisis response in school settings as well. Next slide. As Marci said, I wanted to leave you with some resources here because it's important to have some funding and sustainability of efforts as well. Coming from a public health sector, we always are thinking about prevention. And so having a comprehensive approach is important, and funding a comprehensive approach can be difficult. So I wanted to leave you with some resources here as you're thinking through sustainability of some of these strategies and efforts. Next slide. And here are some additional resources that I think were dropped in the chat from ASTHO in relation to youth behavioral health.
Thank you, Ioana. So in a few minutes, we're about to dive into a moderated panel with the speakers with some Q&A after that from the audience. So just as a reminder, if you have any questions for any of the speakers, please use that Q&A function on the bar at the bottom of your Zoom screen. In the meantime, though, I would like to invite Hanaleah to provide some comments about what's going on in this at the state level in North Carolina. So could you talk a little bit, Hanaleah, about the statewide collaboration activity that's been done in your state around the Unified School Behavioral Health Action Plan?
Absolutely. Thanks, Joey. And I'll keep it brief since I know we're running a little behind on our schedule. So yeah, as was stated, I work for the North Carolina Department of Health and Human Services, and we partnered really closely with our Department of Public Instruction, bringing the support in from ASTHO to think about what we might be able to do in terms of a plan in the school behavioral health space. We were really hearing increased needs from teachers saying that they felt like their students needed more needs, and the data from students was really concerning. I think initially we had contemplated a strategic plan, and upon reflection we realized where we were really at was more of an action plan, something that had some discrete priority areas, things we thought we could get done in the next 2 years. And so we put out a survey to our community partners, asked them to tell us what was most important to them, what rose to the top if we were going to prioritize a few strategies. And what we ended up with was a set of 6 strategies to strengthen our school behavioral health system. So I'll just quickly review those strategies. So our first strategy was building and maintaining an electronic health record system for our schools, something that could safely record information about students' needs and what's worked for them. And also what was most important to us was making sure that when students changed schools, that those records went with them easily, so they could get continuity of care. And then also to really support billing, Medicaid billing for our schools, which is really an underutilized resource. We also proposed building a pilot for telebehavioral health. We did a survey of who was doing what across the state. And what we found was that while telehealth really has picked up in the state, telebehavioral health in schools is really still lagging behind, and that there was a lot of effort needed in that space to build it up. Project Aware, Project Activate, this is something that folks may be aware of. In North Carolina, we call it Project Aware. This is something that does multi-level systems of support. And in North Carolina, we've had 2 phases of grants. And what we really wanted was to be able to stay in the services that our districts had brought in while they figured out long-term solutions that could sustain those resources, things like Medicaid billing, that would help them catch up from the things that they had been doing, but maybe not been able to build sustainability plans into because of the pandemic. For the last couple years, we have been working with COVID funding to support training for schools in bringing in community resources into the schools to partner in care planning for students. And so we're hoping to continue that work and build upon it. We also, with COVID funded, provided resources to local advisory councils that support school health to basically do anything in the school behavioral health space. And we saw just so much creativity come out of that local funding. And so we're hoping to sustain that funding. And then finally, bringing school mental health first aid, youth mental health first aid and teen mental health first aid training to school staff and teens across the state. That's actually something that we're already underway on. So that's our first strategy we're implementing. And we are really hoping and working to get funding for the rest of the strategies.
Thanks, Hanaleah. And at this time, if I could get the other speakers to turn on their videos and join us. While we're waiting for that though, Hanaleah, if you don't mind, could you talk a little bit about kind of the communication and messaging strategies that help promote this action plan in the state?
Yeah, I think a lot of what we thought about was how do we make this accessible and the impact clear for folks? Something like health record system is really not exciting to the average person, right? And so how do we make that come alive for people so they can understand why this actually is so important for kids and teachers? And so what we did was we collected stories. We talked to teachers, we talked to in-school support professionals. We just said, tell us your stories about how this could have had an impact, how this might have changed a student's life. And so we really focused on telling those stories. We embedded those stories into our plan. And so for every strategy, we thought about how do we make this clear about who is the person on the ground who's going to have this impact their lives, and how can we put people in the shoes of a teacher or a student or a parent who might be able to see the impact here. We also really thought about lifting up the evidence for things. We really did a deep dive on the evidence, and you know, things like our local initiatives where we were providing funding to local districts. You know, the average person might have said, well, how do we know what they're doing, you know, is any good? And really being able to lift up, you know, when we gave this funding to our districts, we actually did a project where we interviewed districts about why they chose what they did, what were the conditions that led them to choose those, and then really leaning on where there was evidence for what they were doing to be able to tell that story about why they lifted up what they did, how that was important for them, and also the fact that so many districts, when given the opportunity, did choose evidence-based programs.
Marci, you talked a lot about data in your presentation and may have, for the sake of time, pushed past some of the strategy approaches. So I want to give you a chance. What are some of the best prevention strategies you've seen for elementary, middle, and high school students? And what strategies are not so effective? But also, Selena had added that health education curriculum analysis tool in the chat. I wonder if you could speak a little bit about that and how to tailor those learning standards to different age groups.
Of course. Thanks for the question, Joey. I would echo everything Ioana said. I completely agree 100% with everything she said. The Health Education Curriculum Analysis Tool, or HECAT, is available as an online tool. It's essentially a checklist that school districts can use when they're considering implementing a health education curriculum. There are different modules for topic areas. So there's one specific to alcohol, tobacco, and other drugs. So if you're considering using it, you can run it through that checklist to see if it is actually evidence-based, if it uses evidence-based teaching strategies, if it includes all the key topics that you would want to include, and there are different standards per grade level or sequence. So it's really clear and organized by different scope and sequences. So I would say that. And so health education, as Ioana mentioned, I think is a really great tool to be able to share this information and prevention messages with young people. I would also say school connectedness, kids who feel like teachers and people in the school care about them as people, not just as students, and that the rules are implemented fairly. That's a really powerful protective factor for not just substance use, but for mental health and a whole bunch of other risk factors. So I would say that. And then the third thing, kind of further upstream, is having naloxone available. And I put the link in the chat that the FDA just made that available over the counter. And I can also pop in the chat. I know people are concerned about the cost now that it's over the counter, but there are ways for schools to be able to get that, particularly high schools, to get that for free. So I'll put that in the chat.
Thanks, Marci. And anyone else can react to the questions. It's not specific to either of you, but Ioana, I did want to ask, this is clearly an intersection point for various stakeholders at the state or local level. What are some of the pain points or opportunities that state agencies are facing when they're trying to collaborate on this issue that you've been seeing?
And I'd love to hear Hanaleah's thought a little bit after as well. So I'm gonna give her a heads up. But what we've noticed working kind of at this intersection between health, education, Medicaid, everybody has a different language. And so it feels like you have a different mission. It feels like maybe you have a different goal. So like, I urge people to look beyond the jargon of, you know, shared risk protective factors or social emotional learning programs or this or that, because at the end of the day, we all have the same goal to collectively support students and their families and make sure that they feel like they have mental health, well-being, and all those things, right? And so one of the pain points that we've noticed in working with states at this collaboration is that they get into a meeting and they just throw jargon one to the other. And so I urge you all to just take a step back and think through those initial steps of what is your mission and what is your goal and how can you achieve it together?
Yeah, I absolutely agree with that, Ioana, and I would also add a couple more thoughts. I think one of the things that we're all very aware of is that, you know, educational outcomes are a top priority for educational leaders, right? And so we have to be able to, again, going back to that messaging, think about where can we tie this into educational outcomes? Where can we make that case? And there is a lot of evidence, you know, when you look about the impact that this is going to have, for instance, on absences. School absences are something that school leaders are very concerned about, right? So figure out what are the top priorities for those partners that you are working with. And in many cases, that's really going to align with what we're trying to do here. Another thing I would say is just, you know, a lot of the key partners in the space have been underwater for a long time. You know, schools in particular have been feeling the pain, understaffed, under-resourced. And what we found was if we came to the table all super energized and not really speaking to the realities that they were seeing on the ground in terms of being understaffed, we were going to lose them pretty quickly. And so we had to take a step back and say, okay, we really have to come to you with a proposal that makes clear that we're not asking for anything else from your staff, because that's really a top priority from you. And so we took a step back and we said, okay, how can we reorganize some of this stuff so that we're not asking for more from teachers or support personnel. And when we did that, we found a much greater willingness to engage and a lot more excitement around the strategies we were proposing.
This question's for all of you, whoever might want to answer, but so we saw some data around changes and activity, student behavior activity. What makes the current youth drug use issue different from previous years, or why is today different than 5-10 years ago? And how are states responding to this evolving issue, and how should they be responding from the similar issues, but how they were different in the past?
So I think it's really what I said in my my talk, Joey. I mean, previously, you know, I think folks thought, well, you're just experimenting. You're experimenting with marijuana. You're experimenting with cocaine, but it's not problematic, right? It's not, doesn't turn into a use disorder or daily use or something along those lines. But increasingly with fentanyl mixed in with our drug supply, I think with the mental health crisis that I described and people looking for ways to address depression or anxiety, those pressed pills have become particularly problematic for young people. They think they're just taking something that's going to help them with their depression or anxiety, and it winds up being a fatal decision. And parents aren't aware, right? There aren't prior warning signs of substance use. So it's very scary. So unless we make young people aware of the existence, you know, then they're just at increased risk, again, with social media distribution and messaging related to these pressed pills. It's really changed the calculus of substance use among adolescents. And again, I feel like if we could just address the underlying issues related to mental health, we might have less of youth looking for these medications to address their depression or anxiety.
Anyone else have anything to add to that one? Okay. At the state policymaking, we do love to talk about stakeholder engagement, and we did talk about that a little bit earlier, but this is another question for everyone. How do you ensure all the right people are involved in these activities, and who needs to be at the table and why?
Yeah, I mean, I can start that off. I think that it's really important early on to think about who are going to be the key kind of groups that you need. So you're going to have your key state leaders, right? The folks who might be key holders to the funding that you need, or the buy-in that you need. There's also going to be folks on the ground who you need key information from, who you need to understand their context. And then as you go, there may be additional stakeholders you need to bring in. So for instance, we this telehealth strategy was lifted up. It came in from our survey. Okay, if people want to prioritize telehealth, okay, well, what does that really mean? What could we do in this space in 2 years? What is the cost of these kind of things? What would be helpful for folks who are already working in this space? And we realized we just really didn't have the right people at the table to answer those questions. So we formed a work group and brought in all the telehealth providers that we could find from around the state who were working in this space in schools, to really tell us, okay, where are the gaps? What do you need? And also what's feasible, and they were able to tell us, okay, what you're planning, not feasible. You need to rethink this. And so I think, you're going to have those key decisions makers like your school board, like your people working in schools that you need, that information from. And then you're going to have the people that you couldn't have anticipated, right, along the way, and being that constantly asking those questions about who else do we need to bring to the table, whose perspective is going to be key at this moment.
Did anyone else want to add anything to that, Ioana?
Yeah, I would just add making sure that communities are involved as well. Even if it's a youth serving organization, for example, Maine, which I brought up earlier, has Maine Youth Action Network. So it is a network of youth and young adults. And so they are able to bring that voice. So they are often uplifted in some of these decisions that they make at the state level, and they're involved in that decision making. So how can we make sure that youth, families, communities have a voice in these decisions as well?
Can I just add, Joey, I would again encourage you, I'm going to put the link for the drug-free communities into the chat. Drug-free community coalitions are in almost every single state. They're anxious to collaborate and work with schools, and they're required to work with 12 different sectors. So they've already got kind of a group together. So it might be worth looking into that.
Thank you. And Marci, I did see a question, I think that would be towards you in the chat. How can schools apply for this free Narcan through National Overdose Prevention?
Yes, I'm about to provide, I'm about to put other links there. Sometimes it's state specific, so it kind of depends a little bit where you are, but I'm going to put some other resources to answer that question. Thank you.
Great, thank you. And we have a couple more minutes. Just at this moment, is there anything that you feel like was missed in this presentation? Something we didn't touch on? Is there anything that you'd like to add, and all three of you? All right, if we're good, I'm not seeing any more questions in the Q&A on Zoom. So I just want to thank you all and pass the mic back to Selena.
Thank you, Joey. And let's give our speakers a round of applause. Thank you so much for joining us this afternoon. What a great conversation. Oh, let's see. As we are exiting the webinar today, you will see an evaluation poll. I just ask that you please complete that on your way out. And let's see what else. As a reminder, the slide deck, the recording, and other resources. We have a ton of resources, and we'll make sure that we get those out to you next week. Thank you again for everyone for joining today and contributing to such an important conversation and sharing your great work with our audience. And thank you for our partners, NCSD and Child Trends, for your support. And to NASBE staff, Renee, I see you there. Thank you so much for helping us with the platform management today. I hope everyone has a wonderful, wonderful day. And that concludes our webinar. Thank you so much.